Thanks. Okay, so we're recording. Thank you. Lizette is showing us the slides and we'll follow along there. Thanks to everyone for being here. And I think we'll just go ahead and move ahead. Next slide. We're definitely making progress. So we had a meeting with PCORI a few weeks ago about kind of where we are with the whole project. Their number one concern, I would say, is a valid, fair concern, and that is getting the last 3 sites to launch. We're going to hear more about the issues at those sites today. Hopefully we've gotten some via email, and I'm hopeful we'll hear more in discussion today. So that was the number one, far and away, most important topic. The next topic, we talked a little bit about this supplemental funding, which we'll tell you about in a few slides. And then the kind of what's the next step? Where are we going after this? I think it's a little premature to know because we're still rolling it out. We're up and running at 6 sites. You know, the other 3 are coming soon. We don't have any data to look at to know about improvement yet. But that's their other question of, great, what's the next step with it? Anybody else who was on that call want to add something to that? Lizette, Michelle?
I think that's a good summary.
Okay. Sounds good. So moving ahead. So these are reminders of what the milestones look like. We are, I would say, doing relatively well in a lot of these. A lot of the data ones, we're almost there. The implementation is almost there. We're making progress on that, I would say. That's kind of where we are for this slide. This is probably the one that summarizes the overall, where are we the best? Obviously, we all want to be green. We still have some red spots that are getting the real-time alert ready to go. You know, we just heard, and we'll hear more about Utah, but the key is that last column where it says launched. You know, PCORI is pushing and we're internally pushing ourselves. We need the places to launch. And hopefully, yeah, I think it just got added on that this April 16th, literally today, we got an email about it starting yesterday at Utah. So we'll hear more about that, but hopefully this will all be green by the next time we meet. So the next thing I wanted to talk about, and Brandon's going to take over and talk a little bit about this, is the importance of the data. So people have started to get us data. And as you might expect, it hasn't been perfect, but we knew that coming into it. The ask has been, you know, this all should have been submitted months ago. We're now able to look at some of it, and Brandon will show you a little bit of a snapshot of what it looks like, just to get a feel. Once we have all the data from everybody, we're gonna start giving back some reports with your individual data, comparing it to the group, just to get a feel for where you are. And reminder, this is for 2 parts of data: the registry data for trauma patient registry information, as well as the missed dose data pulled from Epic, or sorry, from your EMR, Epic or Cerner. So this was kind of the ask as a reminder. Most of the places have gotten us most of the data. You'll see on the next couple slides that it's not quite perfect yet. Next slide. So Brandon, maybe you could walk us through what this looks like. We've blinded this for now. So you don't know which is which hospital, which is Stanford or UCSD or MUSC, et cetera. We don't know which ones, and we are not showing that right now. And Brandon, maybe you could just walk us through. This is some data from some of the hospitals for some of the years.
Yeah, so that is a nice. It is some hospital data for some years. There are some sites that are represented with multiple rows because they've submitted multiple years of data. And what you're going to see is, at least in the first 3 columns with numbers in it, the total number of doses prescribed, the total number of doses given, the total number of doses missed, and then eventually the total number of doses refused. You'll see a wide variation in the total number of doses, and that is because some hospitals submitted data for their entire hospital, whereas others submitted only for the floors on which their trauma patients were seen. So please don't be alarmed by the strange numbers that you might see. One thing that became very obvious when looking through the data is that not all sites have a field for refused. So in many instances, the documenting field in the medication administration record might only be given or missed. And then there's probably an additional opportunity for a nurse to type in the reason for the missed dose, which might include refused. So in all of these instances where you see nothing in the refused column or 0% refused, that is not actually 0% refused. It is probably some portion of the missed doses that we're going to try to oh, sorry, if you could, if anyone could, who's on, could mute the, some percentage of the missed doses will actually be refused, and I'll be reaching out to the individual sites to try to get additional fields where there might be some free text information from the nurses. But I think that
one thing on top of that, Brandon, and the other piece to remember is each one of these lines is a hospital for a year. If you count, I think there's 17 rows. There was one hospital, we got 2 years worth of data, not the third. So like Brandon will be reaching out one-on-one to get a little bit more information so that we can have all of the pre-data before we start to share it as a group. And then we can talk about what that's going to look like as well.
But I think that it's also really important to point out that nobody was more than 10% missed doses. So it's definitely something to look at. Now, one of the things to keep in mind is that the site that provided us with hospital-wide information, this is going to include medically ill patients, OBGYN patients, and there might be wide variations. So it's entirely possible that when we refine this down only to the trauma population, these percentages might change and possibly even improve from what we're seeing here.
Yeah, but I think it's going to take a little while for us to get all the data. There's a few like last sites, but I think the idea is we're making progress. We have a little bit of the data. You know, the next steps are going to be to link the individual patient data for missed doses to their registry data. But this just gives us a snapshot and gives us a feel. And I think it made me personally happy to see, number one, we have the data. And number two, it's probably about where we expected it. Surgical patients are missing, you know, less, like Brandon said, less than 10% of the doses. It's still associated with events. We've seen that before. That data is pretty strong. But realizing that it is a problem, not just at JHH, and the numbers relatively ballpark similar across the sites is good to know. Comments or questions on what this looks like at first glance? Great. Next slide, Brandon's going to keep going with a couple different pieces. This slide and the next couple.
Yeah, so one of the things that I noticed from most of the data that was sent to us is that it seems as though the data was pooled using probably an anticoagulation grouper, and we ended up getting a lot of doses that were very clearly for treatment or systemic anticoagulation. And as a result, I ended up whittling down the data that was sent to us really to be more within these categories here conceptually. Heparin 5,000 twice a day, 3 times a day, and enoxaparin 30, 40, 60, and fondaparinux 2.5. When I reach out to individual sites with various things, I will ask to confirm that this is generally the prophylaxis regimens that you use. And I will give a range for what I'm seeing within the data just to make sure and confirm that we're pooling all of the things that you at your hospital use for prophylaxis.
And what I think we might need to do, and this is going to be something we can do via email back and forth, over the course of time that this project has been going on, prophylaxis dosing has changed, and we kind of know that. So, historically 30 milligrams BID was the trauma dose based on, the Gertz paper. But then, and 40 milligrams once a day was the medically ill dose, but people were using that for trauma. We know now that a lot of people are using 40 twice a day in trauma patients. Some places that are modifying dosing based on TAG or anti-10A levels are using 50 twice a day, because that's what it seems to take to get your patients up to the right level based on anti-10A levels, an example, or obesity, things like that. So I think it'd be nice if we could, as a group, come to a decision on what we're going to include, and then it's the same for everybody. Because I think it's hard to say, well, at hospital A, we included these medications, and at hospital B, these are only the ones included. I don't know what people think about that. But it is a little tricky because, when we came up with our definitions, a couple years ago, this was more straightforward. And now, even in the past year or two, there's lots and lots of change. Opinions?
Elliot, so are you saying that, I agree with what you're saying, is that there's been gradual change, but is this feasible to just apply it to these? Because I think when we submitted our list, I think I was kind of as broad as I could be in terms of identifying medications. So I think it sounds like it takes some work to, like Brandon said, whittle it down, but
Yeah,
being more inclusive, because I think like a 40 BID dose, there's not many circumstances where that would be a therapeutic treatment.
right. So, we talk about it in theory, 40 milligrams twice a day. Yes, you could have a 40-kilo person getting therapy, but more likely, we don't see that many people that weigh 40 kilos.
Yeah.
We see a lot more people that weigh, 100 kilos getting that as prophylaxis. So I think my general question for the group is, can we come up with what we think is a list of these? We're going to call these medications prophylaxis, and we might have a little bit of misclassification, but we're just going to have to live with it. Can we agree that we're going to do that, and it's going to be the same for all the sites, as opposed to saying, hey, Laszlo, can you tell me what you use at your site and which sites are modifying based on anti-10A? It doesn't necessarily have in the order it doesn't have the words for prophylaxis.
That sounds very reasonable to get consensus on that.
So if that works for people, I think what what I can do with Brandon and our small group is we can come up with this. Here's the tentative list, and we'll look at some data to kind of give us a feel, just so we know how many of these doses there are, et cetera. And then we can send it around for discussion and do via email, and then have people agree or disagree or something like that. I'm looking around at the rest of the group. Annie, does that sound reasonable? Or
we kind of did this before we pulled any data, narrate our own doses down. So I'm just wondering if everybody already did that, why the need to do it again? Or maybe
I think we're going to have to look at those numbers, because I think, and this was the hard part, where initially we said, well, let each site could kind of give us some different data. We'll have to look at it and see what that number looked like. If you've already excluded, I'll pick 40 twice a day as just an example. If you at Christiana have already excluded that and didn't give us any data, obviously we can't include it. But if we need to change it, we could potentially modify it to match everybody, et cetera. I think part of it's going to have us go back and look at some of the data, and Brandon, we can look at that as a smaller group.
Elliot, I think from our site, we did have 40 twice a day, because our larger patients, I think we pretty routinely, for a larger patient, would do 40 and sometimes up to 60 twice a day.
I agree with you, John. I totally get it. And I think my personal opinion would be that we should be including the 40 twice a day.
At a minimum.
Yeah. So we're going to look at some data, and we're going to send some information around for people to kind of discuss as a group online for kind of what's included and what's not included.
And just to clarify, not every site submitted everything. Some sites, as you described, did provide a very narrow window of prophylaxis doses. It was really only in the instances where I saw 300 milligrams of enoxaparin it took a little added effort to whittle down. But if there is a list that people agree on, I can certainly modify based on that.
Okay. So we'll put that on our to-do list. Next slide, I think this is this philosophical slide that, when we looked at the numbers, this is kind of the concept behind it. For every dose that's prescribed, that dose has to fall into one of these three buckets. It's either given, or it's refused, or it's missed for another reason. And conceptually, these three numbers have to add up to 100%, right? And, the way it's drawn now is, I don't know, 75%, 80% given, 10% missed, 10% refused, whatever that exact number is going to look like. But, as Brandon showed us on a few slides ago, there were places that had 0 for refused. While it isn't entirely possible that nobody refused ever at that hospital, it's pretty unlikely. And we think it's just a data issue. So we're going to be diving down into figuring that out, into that not given bucket, the orange and the gray. How do we make sure we have them broken down into these two broad categories of refused versus missed for something besides refusal? So I think it should hopefully not have zeros in that column, and we're going to keep working on that. And we might have to iterate with each site to make sure we get either drop down answers to, hey, there's another piece of information, there's another piece of data, or if it's right in, that might not be quite as easy. The drop down is obviously way easier for us, but we'll have to talk to you. If you're one of the sites that has 0 refused, we're going to be in touch about, hey, how do we figure out, is it somewhere else in there, and how do we figure out how to get it? Does that summarize the question, at least for people? Laz, I see you on video and you're nodding your head. Does that make sense?
Yeah, it sounds like it, but that question kind of depends on what data you get per site, right?
Correct. And that's where I think, and we would go, what we'll do is, like I said, if you're one of the sites that if your pie chart right now is only blue and orange and there's no gray, we're going to get back in touch with you to say, hey, you might need to pull this slightly differently. There might be another column worth of data for, these are all the ones that are not given, and you've bucketed them into missed, but actually there might be a reason for why, and that's a different element or something like that. So we're going to be in touch with people to kind of iterate on the data, because I think these two pieces are really, really important. Brandon, what else you want to say on that topic? Did I kind of cover that?
You absolutely did. I think that if your site shows 0 refused doses, we'll be reaching out to talk about potentially a free text box.
And I will say that, historically, when we've looked at this before, our very first project, of all the doses that were not given, refusal was the #1 reason. As we've looked at this, across a wider swath, there is variation by hospital. Some is more refused, some is more missed for other reasons, et cetera. But I think the concept is we don't expect that refusal to be 0. And we understand patients are going to refuse. That's totally within their scope. They're allowed to. Our goal is to minimize that to what we think is some lowest as it can be baseline. It's probably not going to be 0 over the course of 3 years. It's just not a realistic number.
So to give a little more example of this, can we go to the next slide? So these are actions that were given within the field. So conceptually, we're looking for given, missed, refused categories. So I did include anything that was marked as given, completed, missed, missed without any additional reason, where we would expect, where things were only either missed, given, not available, so on and so forth, or refused. But then there's a question of, do we include these other doses that are documented as held by provider? Typically, I would think of those as missed doses for one reason or another. But then we also saw a couple of instances where patient admin, family admin, and self-administered via pump. And I don't know if that could just be an instance where somebody accidentally clicked on the wrong thing. At our own hospital, we see several times a year doses of heparin being documented as patient NPO. So we certainly do recognize that sometimes things get incorrectly clicked.
And I will say those last three, for those of us that do a lot of this stuff, you know, those probably feel more like insulin dosing types of things. You know, patients on it has an insulin pump or something like that, and we let them use it. We've got a policy for that at our hospital. You know, in general, we're not having patients self-administering their own, you know, low molecular weight heparin shots. I mean, it's not, it wouldn't be an impossible thing. We certainly do that for people when they go home. But I don't know that it's a routine thing in the hospital. So we'll have to look at what these count as and how many there are and things like that. But this is just as we're starting to look at what this data is really telling us. Comments or questions on this? You'll be hearing more about it now that we have the data to actually look at. You'll be hearing more as we get back in touch with each of the sites. Okay, Lizette is moving us along. So nurse education. So we're mostly, I would say we're mostly done. If Maryland could get a few more, it'd be great. If we could get over 80%.
I have
But as
5
you
done
can
this
see,
weekend.
what's that?
I had 5 of them due this weekend.
Awesome. So I think, you know, we're looking each week. Ashley runs a report the following week and gives us some more information. So that'd be spectacular if we can get a few more in there. That'd be really, really nice. We're going to keep going with that. We'll keep giving you emails if there are updates from your sites. The qualitative interviews are starting and underway. So remember the holdup was a little bit of an IRB issue, which is now resolved. And just as a reminder, we have a group at Penn that's doing these qualitative interviews. We've targeted these 5 sites to give input. Danny Bracey is the research assistant who's going to be doing these interviews. They get recorded and then we're qualitatively looking at all the information. We've given each of the sites has 5 different people to get input. I think it's on the next slide of input from these different people with different perspectives. The trauma surgeon, the PI. So I see some of you on here, the nurse managers on the floors, some of the frontline nurses, you know, bedside nurses, some of the IT people, the alert builders, and then some of the research manager, data coordinator. And a lot of it is just kind of things that we could learn about how to implement this better moving forward as this were to go to other trauma centers, other non-trauma sites, et cetera. So we feel like we're gonna get a bunch of really good information there. So just as a reminder, that's up and running and hopefully people will be able to find the time. We think it's probably about 30 minutes for these interviews. And like I said, there's only 25 of the people, so we really want to try to encourage people to do it. Next up is, so PCORI has some additional funding for projects that they have reached out to PIs and and they're offering additional funding to analyze the cost of implementation. So we put together a proposal for this. It's a relatively small amount on top of the main big grant or contract amount. And the idea is it would give us more information about the business case for adopting this intervention. So it's got a lot of the ideas of, we're going to quantify the implementation costs. We have some people at our school of public health that do economic analysis and all these other pieces. We're going to quantify this implementation cost, whether it's time for nurse training and the education, the interventions, the EHR build, et cetera, et cetera, et cetera. So the general idea is we're going to try to calculate what those costs look like and put that all together. So we put in a project proposal for this. They've come back with some questions that we're in the process of answering. And we just kind of wanted to get the group to understand kind of where we are on this. And then hopefully the idea is, if this were to get funded, we would also have another similar group of interviews with people with a very intent focus on the financial piece of this project. How much do you think it costs for this? And we would give you some more information about it. We have people who do this economic analysis kind of thing for us. Was there one more slide? Oh yeah. So this is some ideas that would be happening about what are the costs at your site? How much would these things be? Some of it might be interview and some of it might be sending you information. We need info on these 2, 3, 4, 10 things, whatever it looks like. To fill us in, documentation via email, et cetera. So that's the general ask for the sites. These are some of the information that we've kind of put together with our cost effectiveness analysis person. This is not a cost effectiveness project. It is a summary of the cost of implementation. And PCORI's pretty clear. We're not allowed to do cost effectiveness on this. But each different site has different costs for these different pieces. So we'd be in touch with you, and then hopefully you'd be able to get us in touch with an administrator who might be able to do some of these things, because they'll talk the language of our cost people here.
Yeah, and I put these next 2 slides in because PCORI in their response to us specifically asked us to come to these 9 sites and ask them to take a look at this and see if there was anything else, or if the team here felt like these would be meaningful to other sites. And so, as you look over the next 2 slides, like if you think of anything else, let us know. That might be helpful when they're evaluating costs.
Yeah, and you can either tell us right now verbally, or, Lizette, maybe we can just send out this small little slide deck for everybody to take a look at and give us hey, that's a great one, but what did you think about, what about this or that or the other? We could certainly add a few elements on, but we are going to be able to tell them, hey, we discussed it on our meeting today. We had representation from a bunch of the sites, and either in general, people gave a thumbs up, or they had some other suggestions or questions or comments.
Sure. I'll send this in a summary email for everybody to look at.
Perfect.
later.
Thanks. So looking at the group, does this, like I said, the vast majority of this work is going to be done by the economics people at our school of public health. We're going to do this piece of it with a little bit of input from each of you at each one of the sites. Does this kind of make sense? Questions, comments on this topic? I realize mostly you're just hearing about it for the first time now, and that's okay. We're going to, like Lizette said, she'll send it around. Okay, and there's one more slide with some more of the other cost type things. And then this just gives you a feel for what the costs of this look like. Okay. Just as a reminder, all the project documents are available on our website. We put that in here every single time so people can remember to go look at the information. So I think for the next, and that was kind of about the first half. The second half is milestones by site, and we should hopefully be able to blow through a bunch of these pretty quickly, especially for the places that are up and running. So we'll go quickly. I think I saw Annie and John on. Either one of you? Any updates? Anything new or different?
No, I think we're pretty much the same. I mean, we're still getting, I've really not seen any change. The nurses are still aware of it. You're still having the periodic refusals. They seem to come in batches when they happen, and you have long periods where nobody does. The nurses know where the paperwork is. So I wouldn't say anything really different for us right now.
Excellent.
And I believe we got reached out on to, I know Annie, myself, and at least a unit manager got reached out to about the follow-up sub-study with the interviews. I don't
Excellent.
know if the IT people did or not, but I know that at least the three of us got reached out to that.
Perfect. And then obviously you don't have to tell us what you said, but maybe next time, hopefully people will be telling us, yes, we met with them, et cetera. And there's a very clearly delineated structured interview guide. You'll be hearing more about it, but thanks for doing that. Thanks in advance for doing that.
Hey, it's Joanne. I agree. There's really no changes. I just ordered more educational print material for the team, so they're using it. Again, every once in a while, we'll have a patient refusal. Doesn't matter what we do or say, they're not going to take it. I am interested in, we do use anti-10A levels and adjust our doses accordingly, but they're still prophylactic. So as you send out that survey regarding what we do, I just want to make sure it doesn't affect us too negatively during this.
No, and it's hard. This becomes a pragmatic question. It's hard when, you're asking people, we're not asking you to change your clinical practice in how you're dosing or anything like that. So we don't want anybody to think that's going to be the case. It's just a little, it's hard when things change because it's a project that's going on over years.
Yeah.
There was a question from Peggy, who's reminder, our pharmacist here at Hopkins. Have the nurses said anything about the alerts being too much work? I know the question was for John because John was reporting, but if anybody, as you report out from your site, if you could help answer that question, that would be super helpful for us. Just, we get that question all the time at other sites. Oh my gosh, this is so much work. Just give us some feedback on if you hear that or if you don't hear that. So John, maybe you guys could start first.
Sorry, I tried to do two things. What was that again?
I can
Have
answer,
you
John.
heard any?
No complaints. I don't think it's often enough to bother anyone.
Yeah, I would agree. When I do go over there, it doesn't really seem like I have a problem with anybody saying, yeah, this is too much work. They still seem like, it's nice to have a pre-planned script. And it seems to not really change their workflow.
Perfect, thank you. Okay, next up is Maryland. I think I saw Paul.
Yeah, so I got 5 more nurses to do the education this week, and that's about it.
Okay. Any issues? Same question, like if things going okay? Any issues, any concerns?
Yeah, no concerns. I actually had one of the nurses this weekend who was like trying to get the team to come up and talk to a patient because the patient was refusing, and he didn't want the charge nurse to come to him and saying the patient refused. So it's
Okay,
working.
that's great. I mean, that's the next step. If patients, if they want to hear from the team, that's great. Okay, sounds good. Oregon.
Yeah, just an update. I think the peer coaching meeting we had, which was late, but I think it went really well. We recorded the session so even more nurses could log in and look at this and see the discussion afterwards. But we basically had all our units right after their sign out login. So we had nighttime nurses and daytime nurses participate. One of the like the positives the suggestions that we got out of it is that we are now integrating the video content into our proprietary hospital system, so patients can access it from their rooms on the TV without like going through devices, which I think can be sometimes difficult to manage if there's like not enough devices or the devices.
No, that's great. And as you know, we let each site do the logistics of how they're showing the video to everybody. And we used to have a system like that. Ours was called TigerNet. And it was like, basically on-demand TV, and we had it built in there, and then it went away. However you guys want to do it so that people can get access to the video, that's great. Thank you. Thank you for the update.
And then I guess the only other thing is like I do audits where I get like a weekly list and look through them. And my impression is that we a lot of like some of the alerts get flagged even though there are appropriate reasons for holding the Lovenox, like complex like complex procedures. And I don't know if that's those cases where it gets held last minute but
Yeah,
we are
I-
kind of getting those alerts. And it's not an overbearing number, but they do filter through.
Absolutely. And I think that's where this question of, what should the number be? Maybe the missed dose number, maybe the goal is not 0%. Maybe the goal is 1%, 2%, 3%. I don't know what the number is, but we certainly know that maybe 10% is too high. So I think your point is valid. And I think each different hospital does it differently. Other places want that medication to be canceled because you don't want the nurses to be documenting it based on some other things. As you know about the Delphi that we did, months ago that we're actively looking on, different people want it held for different reasons. And we don't want those things to be happening unilaterally, not without the decision of the proceduralist, surgeon, whoever's going to be doing those things. But good to know. Thanks for keeping an eye on those.
Thanks.
Stanford, I think I saw Shelley on.
Hi, good afternoon. No, everything is going smoothly. In fact, we were able to have a report created so that I can access it anytime and get the number of refusals based on the population of our trauma patients. So that's a big win from IT. And then with regard to the education, they've actually been incorporating the VTE education in the onboarding of all new nurses coming into the trauma unit. So that's been good.
Sounds great. Thanks. Penn Medicine, I think, Joanne, we heard a little bit. You finish up, make sure we didn't miss anything.
Sure, no, everything's going great. Again, the impact is not significant. I have not received one call, email, communication that it's too much. It's actually going very well. And we also have a report indicating the number of times a patient's refused. And again, that's minimal. So it's actually going very well. Thank you.
Excellent. Thanks. Wisconsin, I think I saw Margo on.
Yeah, no new updates on our end.
Excellent. And that's a totally fine update.
Yes, the nurses haven't complained or anything like that. They just said it's a new routine now and it raised awareness. So
Excellent. And once we've seen that once they get into the groove, they actually like it. It's useful. They have the information at their hands. They have some good teaching materials. So thanks. Utah, I don't know that I saw anyone on.
I think Judy's on.
Yes. Yeah, so good news. The silent launch began yesterday, and we're hoping to meet on Wednesday. And if everything looks good, we might be able to go live by the end of the week, I think.
That'd be great. Thank you for pushing it forth. And I'll just put this out as a reminder to everybody. The Utah group came back to us, me, Michelle, Lizette, asking for a little bit of help to push their IT group. I think not that I'm certainly not taking credit that we did any of the real work, but I think a nice email from me and Michelle on behalf of, hey, PCORI's expecting this to happen. Hopefully that helped a little bit. So if anybody else needs that kind of, this is the contract, it needs to happen. If that would help you with anybody outside of the people on this call, please reach out, me, Michelle, Lizette. But yeah, it's exciting to hear that's getting close.
Yes.
San Diego.
They weren't going to be able to be on, but he sent an email this morning that they are still working. They had a kink where it's not firing to the pagers correctly. And so they're trying to work through that now. They were hoping to launch last week and that's what they ran into. So they're trying to troubleshoot that and they'll get us an update.
Okay. And we know this is an issue and, I'd rather wait if it has to wait another week till it's ready, but that's why I've been trying to push it forth a long time ago. But okay, sounds good. We're making progress there. South Carolina. I don't see anybody on, but I know we've had a few one-on-one meetings with them. They're making a lot more progress than they had been. I would say in the past 2 months, they've made, a ton of progress compared to the previous 12 months. So we're not quite there yet, but we're getting closer and closer. So with that, I think we're going to go over to Q&A. Is there anything that anybody else wants to mention, talk about, ask a question about, tell us or anything like that? Now's your chance. This is kind of the open part. I mean, if not, we can always end 15 minutes early, but I figured I'd at least give everybody the opportunity. Lizette, you or Michelle, anything from the center side?
No, I think we're good. As long, I mean, if anybody needs anything from me, as always, just reach out.
Sounds good. Anything else from the rest of the Hopkins people on? I know you already heard from Brandon, but there's a few more people on. Any other comments or questions from that group?
Elliot, one thing real quick before you go too much further,
Sure.
just because I haven't heard anything. Where do we stand on the, have you guys reached out to extend the data use agreements?
Yes, so my person has drafted it, and I just got an email back where I have to go online and sign my portion.
Okay.
And just so people understand, some of the data use agreements had an end date that was relatively short. Some put an end date that was further out. So if you are getting close to that end date, you'll be hearing from us about extending that data use agreement. So we're sure that we can get all the information back and forth.
Yeah, and just so everyone knows, right now, the only site we're gonna have to update is Christiana. Everybody else is data use agreement is fine for the next few years, so we're good with that.
Okay.
I think we tried to keep them as broad as possible. It just makes it a whole lot easier if you say the project will end in 2025. Some sites are okay with that, and some are like, well, it's only funded till such and such. So John, we will be in touch. I got it via email today. I'm going to try to sign it. I have to print it and scan. It's like a whole big, you know how it's like.
Yeah.
My goal is it'll be back to everybody else by this week. Fair question. Any other questions or comments about anything we talked about, anything we haven't talked about, any other questions from either the Hopkins group or anybody at any of the sites? Okay. To me, that sounds like there's no more topics and we can end a few minutes early. As you know, there's always emails, a flurry that come to me and or Lizette right after the meeting. Feel free to email us with things that you'd rather talk about one-on-one via email.
Thank you, everyone.
Okay, hey, thanks.